It is Thursday, February 9th, and I will call the Committee on Health and Human Services to order. Members, we will be hearing 4 bills today, and we will begin with Senate File 668, Senator Morrison's bill. Is Senator Morrison here? Yes, she is. Welcome, Senator Morrison.
Thank you, Madam Chair.
Take a moment to catch your breath, and you may begin.
Thank you, Madam Chair. Madam Chair and members, I am pleased to present Senate File 668 to the committee this morning. This bill provides funding for family planning special project grant funds, a program established by the Minnesota legislature in 1978. The funding is critically important for people with the least access because of structural inequities and barriers such as poverty, lack of insurance, or transportation. The funding provides access to pre-pregnancy and family planning services, including contraception and sexually transmitted infection, testing and treatment to thousands of Minnesotans across the state. Family planning services reduce the incidence of unwanted pregnancies, STIs, infertility, and cervical cancer. The funding in this bill is especially important in rural areas and communities with barriers to accessing services, and it's critically important in light of the national landscape for family planning and the ongoing legal threats to access to reproductive health care. But I would like to introduce Becky Twanley, Executive Director of We Are the Clinic in Brainerd and Board Chair of the Reproductive Health Alliance, to talk more about the impact and importance of family planning grants on clinics throughout the state.
Thank you, Madam Chair and committee members. My name is Becky Twanley, and I am the Executive Director of We Are the Clinic, located in Brainerd, and Board Chair of the Reproductive Health Alliance, or RHA. RHA is a coalition of 44 member organizations, individual providers, and advocates focused on the problem of inadequate funding for sexual and reproductive health care across the state. Our priority for funding is the family planning grant outlined in Senate File 668. We strongly support the $7.9 million increase for funding of the family planning grant. While the need is growing and STI rates are rising, funding for clinics to address these issues is not keeping up. In over 20 years, this grant funding has increased only 5%. This doesn't take into account inflation or wage increases or the ability for a new clinic or program to access funding. Funding family planning saves taxpayer money through a decrease in teen and unwanted pregnancy rates, reducing the incidence and impact of preterm and low birth rates, and reducing rates of STIs, HIV, infertility, and cervical cancer. This investment of public dollars is equivalent to an estimated taxpayer savings of $7 for every public dollar spent. Clinics across the state just completed a 5-year application for the family planning grant. Awards went to 33 clinics out of 43 applicants. The 10 unfounded clinics are providing services to some of the most vulnerable Minnesotans. A clinic serving American Indian clients in Minneapolis was not funded. The only clinic in the state providing services for deaf, hard of hearing, and blind patients was not funded and forced to discontinue programming. The only clinic in a northern suburb that has served over 1,000 clients per year for over 40 years was not funded. The current funding model is inadequate to meet the needs of Minnesotans and to compensate those providing high-quality, culturally competent, accessible reproductive health services. Affordable access to reproductive health care is critical for vulnerable populations, youth, young adults, the BIPOC and LGBTQ plus community, the underinsured and uninsured. This is even more important in rural areas where transportation, stigma, poverty, and lack of insurance may be more pronounced. If I had more time, I could tell a number of stories of patients who were denied contraception and STI testing based on their age, inability to pay, and provider ideology. These are critical barriers to accessing care, especially in rural areas. Funding is important to fill the gaps and to help us meet our clients' needs. The $7.9 million increase will allow funding for new projects and programs and potentially increase access to contraception and STI testing and medically accurate information across Minnesota. In fact, 47% of Minnesota counties have no family planning clinic, and patients must drive long distances for care. Funding will have an impact on STI rates through increased access to affordable testing, treatment, risk reduction counseling, and condoms. This is important because although they account for only 6.5% of the population in Minnesota, adolescents aged 15 to 19 accounted for 25.2% of chlamydia and 16.3% of gonorrhea cases. People of color continue to be disproportionately affected by all STIs in Minnesota due to differences in health insurance coverage, employment status, and access to health care with preventative screening and treatment services. Funding will increase access to youth-focused reproductive health services that are proven to increase the likelihood of youth attaining education and career goals, raising socioeconomic status, and decreasing poverty rates, as well as improving health outcomes for all genders. Funding will compensate clinics fairly and allow small nonprofits to compete in the healthcare market. While ultimately this investment will save taxpayer dollars, access to family planning affects Minnesotans' education and workforce participation, as well as subsequent outcomes related to income, family stability, mental health and happiness, and children's well-being. We are proud to live in Minnesota, a state that prioritizes affordable reproductive health care. We urge you to take this opportunity to support Senate File 668. This funding is critical to the sustainability of our organizations and to the health of our communities. Thank you.
Thank you, Ms. Twomley, and thank you, Senator Morrison. I will just note for the record that we do have a quorum this morning. So members, any discussion or questions? Senator Utke.
Thank you, Madam Chair. First question is, what is the current rate of funding? The comment was made this 7.9 is an increase. Where are we at in the current biennium?
Senator Morrison or Ms. Twomley?
Thank you, Madam Chair, Senator Utke. The current appropriation is $6.35 million, I believe.
Senator Utke?
Okay, thank you, Madam Chair. And the other question would be, as I read the current statute and then take into consideration what is being processed through Senate File 70, it looks like most of these grants would just be to nonprofits. Is that correct?
Senator Morrison?
Madam Chair, I'll let Ms. Twomley answer that question.
Ms. Twomley?
Thank you, Madam Chair. There are a variety of organizations that are funded. There are county-based clinics, there are federally qualified health centers, and there are nonprofits. I could take a look at the list here.
Yeah, Madam Chair, in one of the handouts, there's one university-operated clinic, 5 local public health agencies, and 17 nonprofit organizations.
Senator Utke?
That's all for now. Thank you.
Senator Abler?
Thank you. Oh, somebody took my little foam guy here. Yeah, good morning, everybody. This topic is not a new one, and we've had many questions. I just have a couple. I'm not going to drag it out. I don't have any amendments to improve your bill, and maybe that'll happen later. But anyway, so there's 33 clinics that get this money, and I'm sorry I forgot your name to the testifier. Unfortunately, some places that have really critical needs and access were not offered. And if I were going to dig into this very long, I would ask the Department of Health, how could you ignore those places over the ones that they did pick? It seems like probably some of the ones that got the money are relatively well-heeled, and it's curious in an administration that's dedicated toward underserved BIPOC equity that they would actually ignore those. That just seems profoundly incongruous to me. So I hope that the department could actually, when they look at the money they're passing out, make sure that they even follow their own desires, which I share many of as well. And so maybe if you can comment about that or not, I don't. But it just seems like in the existing program, it seems like they're failing to address the needs that would be the most essential and doing some needs that are just simply, valuable.
Any response, Senator Morrison?
Madam Chair and Senator Abler, I think it really speaks to the need, that there's just not adequate funding to meet the need across the state.
All right,
Senator
well,
Abler?
So anyway, so yeah, thank you. And just, if I was going to study this, I would look at that. And we're forever, this committee, the list of needs and challenges, if we get a target of $2 billion for this committee, there's still going to be places that aren't going to get what they might have wanted to get. And we forever have to triage. And maybe next time I do talk to the department, they can show me the list of who got it and who didn't. And anyway, so Madam Chair, another question, if I may.
Senator Abler?
And so I'm not sure who knows this, but how many of the grants currently go to places that provide abortions? Do you know that?
Senator Morrison?
Madam Chair and Senator Abler, none of this money is used toward abortion care.
Senator Abler?
Right, but how many places that do abortions get this money?
Senator Morrison? Or Ms. Twombly?
Madam Chair, Ms. Twombly.
I believe, Madam Chair.
Ms. Twombly?
Thank you. I believe that there are 2.
All right.
Senator Abler?
And thanks. In the discussion in the past, and I haven't spent any time prepping for this, I'm just remembering the discussions of the past. And that's a little controversial topic, Senator Morrison. And so we're always told, this discussion has gone on for all my 24 years being here. And the effort has been to segment this money and somehow sequester it from the abortion end. And I've always been somewhat doubtful that you can actually do that. And so I'm just going to express the concern that if this is for family planning and these purposes that we all agree are useful, that I just wanted to raise that point. And given, I don't know, just given the appetites that this body has these days for broadening abortion access, I would like to have the people who are going to be getting this money assure me that it's going to be used for the other side and not find a way to backfill some gaps in their budget.
Madam Chair.
Senator Morrison?
Madam Chair and Senator Abler, I appreciate your comments. I think that, that also speaks to how it's difficult to segment comprehensive reproductive health care into different buckets. But this money is explicitly not to be used for abortion care. And in fact, these grants help to prevent unwanted pregnancies, so it decrease the number of abortions.
Thanks. Just one
Senator
more,
Abler.
Madam Chair. And so I told you I haven't prepped for this, so I don't know. I'm just asking questions I don't really know the answer to. So is there some language in underlying law that directs these not to be used for abortion? Is that true? Or was that ever accomplished? Or is it just a kind of a gentle person's agreement?
Senator Morrison?
Madam Chair and Senator Abler, it is in statute that it is not to be used for abortion care.
All right.
Senator Abler?
And thank you, and I want to commend the worthiness of what you're trying to do. But I think part of our duty, back to my earlier question, which is, I think, perhaps the more substantive part, is that it's our job to encourage the department to do the right thing for the right people. And on this one, I really do want to see the list, and I want to see who got it and who didn't. And if you're worried about underserved, okay, thanks. Well, I appreciate that, so I'll look at that. But it's our job, I think, to push the departments to do their best and highest work. So thank you. That's all I have, Madam Chair.
Senator Liskey?
Thank you, Madam Chair. Madam Chair, Senator Morrison, I'm looking through the grant and the fiscal notes and things like that, and I noticed that it's about $1 million more per year than the governor's recommendation, and that in the governor's budget it allocates another 3 FTEs. How much of this grant or this appropriation is going towards administrative costs, and why are we adding new employees?
Senator Morrison or Ms. Liskey? I'm sorry, Ms. Twombly.
Thank you, Madam Chair. Senator Liskey. I guess I'd just like to clarify, are you asking adding 3 FTEs on the government end, on the MDH? That's the governor's budget, and I don't have that information. I can share with you how we got to the $7.9 million increase.
Senator Liskey.
Okay, I guess that's kind of what I was just trying to figure out is, okay, are we adding because of an administrative cost thing? Are we adding because there's more need for the grants? That's, I guess, what I'm trying to clarify.
Senator Morrison.
Thank you, Madam Chair, and thank you, Senator Liskey. That's a great question. And the intent of the increase is to meet the need, not to increase administrative costs.
Senator Liskey.
That's all, thanks.
Other questions or discussion, members? All right, seeing none, this bill will be laid over for possible inclusion in a future omnibus bill. So thank you, Senator Morrison.
Thank you, Madam Chair and committee.
And with that, we will move to the next Morrison bill, Senate File 164. So Senator Morrison, please proceed.
Thank you, Madam Chair. Madam Chair, members, I do have an amendment. I don't know if members have that amendment. I don't know that I have that amendment.
Members, the A2 should be in your packet, and so Senator Morrison would like to move the A2. Senator Morrison, this is an author's amendment to put the bill in the shape in which you would like it, is that correct?
That's correct, Madam Chair. Thank you.
All right, members, Senator Morrison moves the A2. All those in favor, say aye. Aye. All those opposed? And the ayes have it. The motion prevails and the amendment is adopted. Senator Morrison, to your bill as amended.
Madam Chair, there may be a second author's amendment. I thought it was all included in one.
Okay.
I don't know if the committee has that one available or not.
We think we just have the one amendment,
Yeah.
Senator Morrison.
My understanding was all the changes were included in one amendment.
Madam Chair, committee members, all the changes were included in the A2 amendment.
Thank you.
Thank you. Senator Morrison.
Thank you,
to your bill as
Madam
amended.
Chair. Madam Chair and members, thanks for the opportunity to present Senate File 164, a bill that would allow women to receive long-acting reversible contraception in an inpatient setting postpartum. Minnesota is one of 6 states that hasn't used guidance released by CMS in 2016 that outlined payment approaches other than state Medicaid agencies use to optimize access and use of LARC, or long-acting reversible contraception. LARC methods like IUDs and subdermal contraceptive implants are among the most effective forms of contraception. They can be placed immediately following delivery, prior to hospital discharge when it is convenient for the new mother. It's important to know that LARC device and placement procedures are a covered benefit by private and public insurers in an outpatient setting, meaning the postpartum person could come back at the 6-week postpartum visit or sooner, and the cost of the device and placement would be covered. This does not represent a new benefit. There are many reasons why a patient would prefer immediate postpartum placement. There's convenience for the patient in the inpatient setting. Many patients are motivated to have contraception that they don't have to worry about managing on a daily basis. And women are at risk of unintended pregnancy in the period right after delivery. Resumption of ovulation can occur shortly after delivery for some. And studies show that between 40 and 57% report having unprotected intercourse before the 6-week postpartum visit. Pregnancy spacing is an important part of family planning, and people should know what options are available. Counseling should occur throughout pregnancy and include a discussion about the advantages and disadvantages of all methods. All women should have autonomy in their contraceptive decision-making. For some people, immediate postpartum placement of a LARC is the best choice for them. It's also important to note that under the Affordable Care Act's contraceptive coverage, IUD removal must also be covered without cost sharing. Given the reproductive health care landscape in the United States, it's more important than ever that women have access to reliable, effective contraception that's right for them. Most states have allowed hospitals to bill for the cost of the device outside the bundled payment hospitals receive for labor and delivery. LARC placement is a covered benefit, and the timing of when women get them shouldn't matter. Let's ensure that Minnesotans have this option if they want to. Madam Chair, I do have Dr. Leslie Jager, sorry, doctor, representing the American College of Obstetricians and Gynecologists here to testify.
Dr. Jager.
Thank you. Madam Chair and members of the committee, my name is Dr. Leslie Jager, and I'm here to testify today on behalf of the American College of OBGYN in support of Senate File 164, which would allow for the placement of long-acting reversible contraception, better known as LARC, in the immediate postpartum period. ACOG would like to thank Senator Morrison for authoring this legislation, which is an important choice for women to have when considering contraception options. Placement of LARC in the immediate postpartum period, which is defined within 10 to 15 minutes after delivery, aids women in birth spacing and helps avoid short interpregnancy intervals, which are associated with adverse obstetric and neonatal outcomes, including preterm birth, low birth weight, and infants being small for gestational age. I would also like to add, since 50% of pregnancies in this country are unplanned, and unplanned pregnancies are more frequently ending in a termination of pregnancy, this would also be a way to affect the abortion rate in our country. It is convenient for both the patient and the clinician, as the patient is already in the midst of care, and because roughly 40% of patients do not attend the postpartum visit for a variety of reasons, such as lack of transportation or childcare options. Despite the convenience of immediate postpartum LARC and the high satisfaction rates for women who receive it, it is still an underutilized contraception option, and in Minnesota, that is because our state has not followed the Centers for Medicare and Medicaid Services guidance released back in 2016 that encouraged state Medicaid programs to increase access to LARC and provide coverage in the immediate postpartum. The main barrier that I have in my practice to offering LARC in the immediate postpartum period includes lack of reimbursement for the device cost that exceed the global delivery fee. The cost for the device itself is $700 to $800, and that is not reimbursed currently by any payers. Many state Medicaid programs and commercial insurers have developed their own reimbursement procedures, allowing hospitals and physicians to bill outside of the global delivery fee to make this option available to women. We do want to make clear that LARC can be a covered benefit, that it is not a new benefit. It only changes when the patient might receive it. Providing immediate postpartum LARC to women who want it is an evidence-based, patient-centered, and safe practice. I'd also like to give 2 examples of situations where it would highly benefit patients that I have seen in the last 6 months. As part of my work in rural Minnesota outside of the metro area, I oftentimes deliver women who travel an hour to seek care and oftentimes don't come back for their postpartum visits. If we had availability of LARC while they were in the hospital at the time of their delivery, they would have a safe, effective methods of contraception going forward and be able to safely space their pregnancies. I also work with young moms who sometimes don't have driver's license. Their mothers have to bring them in for their visits. Their mothers work outside the home, and so once the baby is born, further care is difficult because now they have to bring a young child with them. They oftentimes don't show up for their postpartum visits, and these are the women who are more likely to have unprotected sex in the first year after delivery and then have an unintended pregnancy. Thank you again for allowing me to testify and for hearing Senate File 164. I'm available for any questions.
Thank you, Dr. Jager. Members, discussion or questions? Senator Ecke.
Thank you, Madam Chair. And just for clarity, because when I first read this, I had 2 notes on here. it looked like a mandated coverage, and then I was wondering about the cost. But what you're telling us now is there is no additional cost because these things would be paid for if they were 30 days, 60 days, 90 days later. This is just the informational part, just letting them know that this is available.
So
At
right
this
now.
Dr. Jager.
Okay, sorry. Currently, the practice is that the hospitals do not allow us to place these because the hospital would be responsible for the cost of obtaining the device, and they would not be able to bill for it outside of the global delivery fee.
Okay.
And I would not be reimbursed for placing it, which is the minor part of it. It's more the cost of the device. So that's why hospitals won't allow us to place them, because they can't be reimbursed.
Senator Aki, I will also just note that a fiscal note has been requested, but has not yet been completed for this bill.
Okay, there is a fiscal note coming, okay.
Correct.
Okay.
Senator Morrison?
That'll answer some questions too, so thank you.
Yeah, thank you, Madam Chair, and thank you for the question, Senator Aki. It is a covered benefit, so it's sort of a semantic thing, and it's a way that we just need to shift the policy so that it continues to be covered regardless of where it's being placed, whether it's in the hospital setting or the clinic setting.
Senator Aki, any follow-up? Okay. Senator Abler?
Well, thanks, and, I think it's a worthy project you're undertaking here. I just had an observation. As we've gone through the discussions at some length on different topics, this says on line 1.6 on the amendment that the primary care provider is required to develop and implement protocols to share with the patient, the client, whatever you're going to call them in this situation, the full range of options. So like they must talk about that. When we were discussing informed consent when it comes to abortion matters, I was told actually by you and your colleague that we shouldn't be telling you how to run your practice because you're certainly going to be responsible and accountable, and there's no need to tell you what you need to talk about. This bill calls for that. Yesterday we decided that we can't talk about certain things, and so I just think it's interesting and frankly somewhat inconsistent in that. And I don't know, actually on this matter, I don't know why I have to tell you. Like, actually, you're telling me you brought the amendment. So I want to be told that I have to do this when the doctors I know who are engaged in this niche make every effort to do this anyway, in keeping with your earlier thoughts. And so can you tell me why you think you have to be told to do this?
Senator Morrison?
Madam Chair and Senator Abler, thank you for that question. That's a fair one. This language was developed in conjunction with DHS, who preferred to include it. And I think that it acknowledges some of the abuses that have happened in the past in terms of reproductive health care in this country. So there's been a lot of conversation around making sure that this is not coercive, and of course it isn't. It is part of comprehensive reproductive health care, but this is language that DHS preferred.
Senator Abler?
Madam Chair, and I'm not going to go back to relitigate the whole conversation from the last time we were having this discussion, but some of us think in other areas there has been some gaps, which is why we were encouraging informed consent with regard to the abortion services, which we feel are actually under-warned as well. So I just had to point that out, and I sometimes as we're legislators and we're the hammers, everything's a nail, so we legislate, we tell people what to do, and apparently there's DHS sees a gap here. I would be surprised in your practice that there's any gap whatsoever. Nothing's going to change when you're told you have to do this because you would do it anyway. And sometimes the rest of us feel in other areas there are gaps, especially when there's, I'm not going to go back in that discussion, but I appreciate your comments, and I just thought you would like the observation. Thank you.
Thank you, Senator Abler.
Other discussion or questions, members? All right, seeing none, this bill will also be laid, Senate File 164 as amended, will be laid over for possible inclusion in a future omnibus bill. Thank you, Senator Morrison.
Thank you, Madam Chair and members.
All right, members, next we will move to Senate File 406, Senator Mann. Okay. Senator Mann.
Madam Chair, you said 406, right?
406, correct.
Thank you, Madam Chair. Good morning, members. Senate File 406 establishes a person's right to have a support person available to them while getting health care, specifically pregnancy care. Having a trusted support person, especially during labor, is one of the recommendations from the House Select Committee on Racial Justice report and the stance of the World Health Organization, because evidence shows that birthing people who have access to a support person have better birthing experiences and have better health outcomes. We do need to take steps to improve maternal health outcomes. In the United States, maternal morbidity and mortality rates have doubled in the last 2 decades, while they continue to decrease in the rest of the world. We have approximately 24 deaths per 1,000 live births in America, and the next economically comparable country is France, and they have less than 9 deaths per 100,000 live births. We have the highest rates of maternal deaths of all industrialized countries. Having a support person available is one small, evidence-based step that we can take to curtail those numbers. With that, Madam Chair, I do have a testifier.
Thank you, Senator Mann. Ms. Mitchell.
Thank you, Madam Chair. My name is Keisha Mitchell, and I am the Program Manager for the African American Babies Coalition and Projects at the Wilder Foundation. I am also a member of the March of Dimes Mission Impact Committee, Birth Equity Community Council, Healthy Black Pregnancies Collaborative, also known as ICHIRP, which is the Integrated Care for High-Risk Pregnancies group. The Wilder African American Babies Coalition and Projects, affectionately known as AABC, began in 2005, and our mission is to promote healthy brain development for Black and brown babies. As a grassroots organization, our work is centered on prenatal care, the social determinants of health, parenting and child development, and reducing the education and economic gaps for the Black and brown communities. We address these gaps at the family and systems level. With that being said, I am here today in support of Senate File 406 as it expands the state's Patients' Bill of Rights currently in statute and establishes the right for a pregnant patient to have a designated support person while receiving health care. The issue of laboring alone and the increased risk has gained national attention, and OneChange.org petition on the subject garnered more than 600,000 supporters. During the pandemic, restrictions have resulted in pregnant patients giving birth alone, or essentially banning doulas. Decisions to separate families during and after childbirth is harmful and can have long-lasting implications. It can have impacts on mental health and also endanger patients' physical health. A spouse, partner, or another family member can provide physical and emotional comfort during prenatal visits, during labor, and postpartum. They are also essential in alerting staff when something goes wrong and laboring patients cannot notify nurses themselves. We hear stories of patients who experience significant and severe morbidity events during labor and were unable to call for help. The reason this bill is so important to me specifically is that when my sister went through labor, she immediately developed a condition called HELP syndrome, which is elevated liver enzymes and a low platelet count. Her brain was swollen and she was in a coma for 3 days. At that time, her spouse was there advocating for her health while she was fighting for her life. I have no idea where she would be if she didn't have that type of support. The prenatal period, labor and delivery, and the postpartum period are a time of vulnerability. Research shows that patients benefit from having support they trust. Benefits include decreased need for pain medication, shorter labors, fewer C-sections, and that is notable because the risk of death following a C-section is 5 times higher than a vaginal birth, and more positive health indicators for infants with higher APGAD scores. Furthermore, the data on giving birth in the United States is terrifying. Black women are 3 to 4 times more likely to die from pregnancy-related causes, and you can control for all the factors. You can control for education, income, family status, general overall health, weight, insurance status, mental health, and substance use disorder status. And we are still more likely to die. This is with the full knowledge that vast majority of the deaths, over 80% of them, are preventable. The ability to have someone who can speak up for a patient in crisis can be the difference between life and death. Furthermore, 1 in 3 women report that their birth was traumatic. Another disturbing data point is that 28% of women birthing in hospital report being mistreated, such as being shouted at, threatened, physically restrained, ignored, and having treatment withheld or being forced into treatment that they did not want. The goal of this bill is a recognition that a spouse or another support person play a distinct role from a midwife or doula. And with the known risks and vulnerabilities, each play a crucial and critical role. Thank you, Madam Chair, and the members of this committee for allowing me to provide our perspective. I urge you to support Senate File 406, and I'm happy to answer any questions that members may have about the African American Babies Coalition and projects. Thank you.
Thank you for your testimony, Ms. Mitchell. Senator Mann, do you have an amendment?
Yes, Madam Chair. I'd like to move the A4.
Senator Mann moves the A4. All in favor of adopting the A4, please say aye. Oh, it should be in your packet, members. It should be in your packet. We'll wait a moment for folks to find it.
It is an author's amendment, Madam Chair.
We'll wait just a moment to be sure members have the A4. Okay, it is online. Will we get copies? Okay. We'll be sure members get a copy of the A4. Senator Mann, it is an author's amendment to put the bill in the shape in which you would like it to be heard.
Yes, Madam
correct?
Chair.
Senator Ecke?
Do we have the A4 coming?
Yes.
I don't want it, I mean, a printed copy.
Can we get printed copies? Members will get printed copies of the amendment. Senator Morrison?
Madam Chair, I have the amendment here, and I believe it's the A1. Oh, okay, never mind.
All right, just clarification, it is the A4 we are awaiting, and copies are being printed, so we will be sure members get that. Senator Abler?
Well, while we're waiting, if we could just do discussion.
Certainly.
Well, I want to thank you for coming, Ms. Mitchell. And Senator Morrison, you live in this world, I don't, but your testimony is horrifying and tragic in the world that we're in now. And I don't know if the Hospital Association, everybody's going to come and testify about why they think it's okay to have 28% of people threatened about various things. But I mean, that is not what we think is happening out there. That's news to me. And I'm sorry you have to have an organization to try to repair this. And I didn't know that 3 to 4 times mortality for black women as opposed to others. And I know a fair amount about this just from my experience. We had 6 kids. And so the whole discussion of birth mortality and Minnesota and America's standing in overall health statistics is not impressive with how much we spend. And that's a whole different discussion for a different day, which, Madam Chair, maybe we can find some way to help Minnesota be better at the head of the pack of that stuff. But did you say, Ms. Mitchell, that somebody was banning doulas? Did I hear you say that?
Ms. Mitchell?
Thank you. Basically, what I was saying is it's essentially banning doulas. So what we are finding is that when you limit one person into a birthing room, that person has to choose between their spouse and a doula. And that's the purpose of this bill, in order to effectively recognize how important a spouse is and also how important having a doula and midwife.
Oh, yeah.
Senator Abler?
Madam Chair, to me, that's kind of shocking. The last birth we had was at St. Joe's. I got sworn in for the first time in 1999. And so at noon, and then at 5:40, my wife delivered at St. Joe's. And there was a small army of people there. We had, I think, 2 women helping her, and then I just was kind of the fifth wheel. And so St. Joe's was very advanced in their midwife unit, and it's just disappointing. We have to pass a law to say, let you have someone besides. And in my opinion, the doulas have been very helpful, partly because, and Senator Morrison, you probably appreciate this, with the different health plans and who's on, and it's like a dial-a-doc who you're going to wind up with compared to, we've had some home births, and you have a consistency of a midwife who comes in, and that's been good for a choice for us. And then the hospital thing was also very satisfactory. And so I commend you for that. Wow. And so I had a question I was going to ask on a different topic, and I'm not even going to ask that question. I'll take it offline. We spend a ton of money out of this committee on providing health care to you and Ms. Mitchell and to a whole bunch of other people. $3-4 billion, something like that. And we think that we're getting a return on our investment by the HMOs and the various providers. And I would, to the clinicians here, I think that if this is truly going on, we should have a hearing and drag the different executives from the different groups here, both, drag Blue Cross's CEO and drag in, I don't know, Alina's CEO, and tell us how life is going out there and then have them sit and have to talk to you. That'd be great, because I think that we don't, I'm seldom shocked, but I'm shocked. And I'm happy you're here, I'm happy the bill is here. If we have to pass a law saying, would you please let somebody else come along so that a person may not die, where have we come? So. Anyway, so Senator Mann, you got a good bill here. I'm happy to support it. Ms. Mitchell, any way I can go to support you and the needs you have brought forward, I would happily be on board with that. Thank you very much.
Senator Morrison?
Thank you, Madam Chair, and thank you, Senator Mann, for bringing this bill forward. Thank you so much for being here. Also, Ms. Mitchell, with your really shocking testimony. The maternal mortality crisis in the United States is our collective shame. It's not a Minnesota problem, it's an American problem, but we need to do what we can here in our state. And there's all kinds of good evidence, as you shared, that doulas make a big difference in maternal and infant outcomes. So putting it in statute, I think, is a great idea. Hopefully it is already starting to happen in most of our hospitals. I know it at least is in the hospital that I have practiced in. And I appreciate Senator Mann's exception to those rare chaotic circumstances where there is a true emergency, and sometimes it's difficult to have 2 people in an operating room, for example. But I am just very supportive of this effort, grateful for all that you have done and for being here today to talk about this American tragedy. Thank you so much.
Madam Chair,
Senator Abler?
maybe you want to move the amendment. I have a comment about the amendment.
Yes, members, let's address the amendment if we could. So Senator Mann has moved the A4. All those in favor
Madam
say...
Chair, no, I would like to discuss the amendment.
Oh, very good. Senator Abler.
Thanks. This worries me. Ms. Mitchell, if you read this amendment, it says they don't have to let them in because they're going to decide it's necessary to maintain a safe environment. What does that mean? You might wind up with a bill that has no effect. The people that are not letting you have a doula in there already, St. Joe's was happy to do it. Like, oh, you know, as many people could fit in the room. And I just want to caution the author that you're opening this bill up to be nothing again. Any restriction must be subject to the facility's internal written grievance procedure. Well, how's that go? I've been talking to nurse after nurse about how they go to work and get hurt and nobody seems to care. And to the point that they quit. And there's an internal grievance procedure that they get to go through, which doesn't work either. And so, I mean, adopt it if you want. I'm going to vote no. But I think as you go forward with this, if you really want to help the Miss Mitchells of the world and people like that, I think you want to use the word emergency and not let the facility decide that it's to meet the appropriate standard of care for medical practice is in the best interest of the patient's care or patient safety. What does that even mean? Or to mean a safe environment for guests, clinicians, and staff. It's really vague. And so maybe you're going to vote for your own amendment, but I'm just cautioning you. You might wind up with a bill that has no effect. That's all. Thanks.
I'm going to go to Senator Mann, and then I do want to take a vote on the amendment. As is custom, this is an author's amendment, and so we certainly can have discussion about the amendment, but I would like to take a vote and then do that. But Senator Mann, I'll let you speak to that first.
Thank you, Madam Chair. So the amendment is, the purpose of the amendment is two different things. One is when a patient has a emergency C-section and has to go into the operating room, and we have to keep operating rooms sterile and clean. We cannot allow a bunch of people into the operating room. So that simply says for its appropriate standard of medical care, we're not going to allow a bunch of people in an operating room, essentially, and for the best interest of the patient's care and patient safety, same reason. The following is to have a safe environment for patient, guests, clinicians, and other staff. This was brought to us by social workers in the hospital who said that every now and then a family member of a patient becomes violent, becomes abusive to the staff, and that person must be removed from the patient care setting. And so this language allows the hospital to do that, again, for appropriate standard of medical care and for patient and staff safety.
Thank you, Senator Abler.
And so, I mean, just to back up, the idea of author's amendments being automatically adopted without discussion is a really bad idea, just because they want to put something on a bill, especially when it's this sort of amendment where it's just suddenly put upon us. The public doesn't know what it is, and not so much, you know, this thing, and the author seems comfortable with it, but it's not a good practice. And so a bill is introduced. You could write the bill any way you want, and the thinking is, if you want to change your bill, you could have changed the bill earlier, so you still get to have the privilege of your bill. That's the idea behind it, but in earlier meetings, I've asked that an amendment be explained, and it was not, which I think is just not a good practice and not good for the institution. But now, just one more thing to the amendment. Senator Mann, and to the public, I think that this discussion, I think, is actually trying to be helpful to your cause. And so if it's clear that this amendment is brought into the bill, which is almost certain to become law, that it's not the intent that this is used very often. This is used in the rare situations when it's truly not in the best interest. But I'm just, and so to the hospitals out there and whoever is listening, this is not meant to be a way to prohibit a doula in a regular room, on regular circumstances, or prohibit the spouse or friend or whoever you're going to bring along. And that wouldn't be so upset about this, but for the testimony of Ms. Mitchell, which I did not know was going on. So I'll stand down at that. Thank you.
All right, members, and so just, I'll restate again that this is an amendment, I'll come to you in a second, to put the bill in the shape in which the author would like to hear it, as is, and has been explained and is public for people to see and read. Senator Morrison.
Sorry, Madam Chair, thank you. I just wanted to point out that the last sentence of the bill says certified doulas and traditional midwives may not be counted toward the limit of one designated support person. So we're actually talking about 2 people or more potentially.
Thank you, Senator Morrison. All right, so with that, members, Senator Mann has moved the A4. All those in favor say aye. Aye. All those opposed? The motion passes and the amendment is adopted. We do have an additional testifier, Natasha Chernowski. Please come forward. Please introduce yourself for the record and proceed with your testimony.
Good morning, Madam Chair and members of the committee. Thank you. My name is Natasha Chernowski, and I'm the Legislative and Policy Specialist with Citizens Council for Health Freedom. And we are an organization that advocates for patient freedom and doctor freedom. And today we're very thankful to Senator Mann for bringing forward this bill, as we believe it's a really important piece in protecting patient rights while they're hospitalized. I think the previous testifier did a wonderful job of identifying the issues currently in the system, but I wanted to just share earlier, last fall, our organization received a call from a soon-to-be grandmother who was frantic because she and her son-in-law were barred by the hospital administration from entering and being present at her grandson's birth, and her daughter was forced to undergo labor alone without the previously planned support of her mother and husband present. And we just strongly believe that there shouldn't be a circumstance like this, where a patient has to undergo hospitalization, which is a really vulnerable and frightening time for most patients, especially when they may be under the influence of medication, they are in pain, or just not at their complete wits to be able to understand the treatment possibilities and potentials there for them. And we really do believe it is vital that they have someone who can advocate for them and on their behalf, someone who can communicate their needs, their medical history, their requests to a hospital administration, especially if it is an extended period of time and there's a busyness of the ins and out of a hospital staff, to have someone that is constantly with the patient that they trust, and to be that comfort for them as well. We just do not believe that hospitalization should equal isolation, and that is a common theme that we've seen, not just for women who are pregnant and in the hospital for that reason, but that this is something that's common for a multitude of patients, and there shouldn't be a reason for them to be ever separated or denied access to a designated support person. So we do really appreciate this bill. We support it full-heartedly. Our only suggestion would be to make it something that applies to all patients, that this would be a right for any person that is hospitalized to have a designated support person, to be that communicator, that comforter, and somebody that is present in the room at all times. And we understand there are certain exemptions for, operating or emergency critical care issues, but that patients should have that right as a whole. So that would be our one suggestion as an improvement to this bill, but overall, I really do appreciate being brought forward. Senator Mann, thank you so much for addressing this issue.
Thank you, Ms. Chernowski. Members, other discussion. Senator Liskey.
Thank you, Madam Chair. Senator Mann, testifiers, thank you for coming forward. I agree in what you've just said I would really like it to maybe broaden a little bit from just about pregnant women, but also to the whole spectrum of patients that might need a support person. I want to talk to this as I actually personally experienced something similar to this with my wife. My wife was pregnant with my now almost 3-year-old daughter during the COVID era of pretty serious lockdowns at hospitals. And so the amendment is slightly concerning in the fact that we talk about determination of safety and medical practices, and up until the amendment, I was in full support of this bill. And now I'm slightly concerned because if we have another pandemic situation, the wording of this paragraph C would allow the hospital to, again, lock out the possibility of a support person, and that's concerning to me. We were 2 weeks before my wife's delivery. She was told by our provider that there was no guarantees that I'd be allowed in the room. Luckily, there was lots of research done in a very short amount of time on proof of what we're talking about here and how there's very bad outcomes if you're not allowed a support person. So they changed the rules at the hospital, but for an entire week at the hospital we were going to, they did not allow a support person. So that is something that, by reading paragraph C, I get concerned that this now opens the door to that type of argument and discussion.
Senator Mann, any comments?
Thank you, Madam Chair. I mean, we can certainly tweak that language, but again, the intent is to make sure that we're not, keeping violent people in the hospital, and we are not compromising sterile work environments. But I can see what you're saying.
Senator Liskey?
Thank you, Senator Mann. And that's really my concern, is the way it's worded currently, is it does change that standard care of medical practice. Well, okay, if we do that, the standard care during pandemics are not allowing a person in the room. So that's my concern. Thank you.
Senator Abler?
Well, thanks, and I'm moving to a different element, so that's good news. Anyway, so Ms. Mitchell, and I'm still just, I am seldom shocked here anymore, but you just have got my attention. So you said that black women are 3 to 4 times more likely to die in childbirth, which I knew there was a disparity. I did not know it was that extreme. Does anybody know, is that kept track of, like, by the Department of Health and, like, by site and by some circumstance, so that a person can try to figure out how that might be avoided? Does anybody know that?
Ms. Mitchell?
Thank you so much for the question. You can find the statistics on a CDC website, but the Minnesota Department of Health also tracks that as well. The March of Dimes also has a tracker for it, not only that, but for also premature deliveries as well.
Senator Abler?
Sure. It just seems like, as a policy matter, Department of Health and I we have a kind of a mixed relationship here, but if you haven't kept track, but they're charged with public health. Mm-hmm. It seems like black women dying during childbirth would be a public health, like, crisis, like a big deal. And so maybe when we have it offline between you and the new commissioner and others, this cannot go on. It just cannot. And so, not to belabor the discussion, Madam Chair, but this 28% felt threatened. Is any record made of that? I mean, do the threatenees complain to the hospital? Is there a formal way that they can follow up? And I'm curious if 28% of black women feel threatened and 10% of Caucasian women feel threatened, or if it's a disparity about that, but that's entirely unacceptable. Do you want to comment, Mrs. Mitchell?
Ms. Mitchell?
Thank you so much. I have 2 comments. The first comment is that on a county level, there's a lot of work that's being done that I know of. There's the Birth Justice Collaboration, and that is in Hennepin County. And then there is the Birth Equity Community Council that's in Ramsey County. And they are taking this as a public health crisis. And we are doing a lot of work in order to see movement within the numbers. So you have a lot of boots on the ground, and I really do appreciate your questions. The second part of your question, as it relates to, I lost my train of thought. What was may I ask what the second part is?
Senator Abler?
Oh, well, is it reported to anybody? Like is there a disparity by race? But then is anybody collecting this information? Because it certainly would lend itself toward worse outcomes and very things that
Ms.
the author wants to fix.
So I do not have the research on that. What I can say is that most hospitals do have a complaint process and a procedure. I used to work for the Minnesota Department of Health as a health professional. I designated health professional shortage areas. So I worked with hospitals all across Minnesota, the 87 counties, they do have a complaint process, in order to research when a woman is are having issues. What my experience is more geared towards is the women that we have in the Black women, people of color that come to us and they talk to us about about their birth plan and what happened with their birthing stories. And that is something that the African American Babies Coalition and Projects actually has in their, we have a summit every single year, and that's something that we are working towards this year.
Well, thanks. And Madam Chair, I'm not going to take all day on this.
Thank you.
But I think you've got a bill that, Senator Mann, I think what you've got was, you have a bill that's a very good bill, and you might want to clean the language up, but you've got a really important piece of legislation that is actually going to make a dent in some of this. But I think in doing so, we've uncovered another angle that at least I was unaware of, and I don't know if everybody else has been aware of this threatening and the disparity part. So I think that by doing one good thing, I think you're going to provoke some more action to do some more good things. And I had a couple of very good dialogues with Commissioner Cunningham, and she, I think that she's really interested in these kind of things as well. And it's just the right time. So anyway, I'm done. Thanks.
Madam Chair.
Senator Mann.
So because these disparities have been going on for decades upon decades, but certainly in the last 2 decades, we've seen this increase in maternal morbidity and mortality, especially for Black women and women of color. The conversation certainly is not new. So there's a lot of data out there to show that even when you correct for education, socioeconomic status, age, you essentially even out the playing field. Black women still die at 3 to 4 times the rate of white women. We can talk about also when the same group of people, when Black patients have Black doctors, their outcomes are better, right? So systemic racism certainly plays a part in the outcomes that we're talking about today. And again, this, it's nothing new, but I appreciate that we're having these conversations and people are being more aware of what's going on, because there is a lot of work to be done, and we can certainly all work on that together.
Thank you, Senator Mann. Senator Morrison.
Thank you, Madam Chair, and Senator Mann. I just wanted to add thank you for your last comments. I think that's important. This is a problem that we've known about for a while. That is, again, I will repeat the words American tragedy. And it, and again, the maternal morbidity and mortality crisis in the United States stands out among our peer nations. We are the worst. And the impact of systemic racism obviously is a piece of why this is happening. The inequities that exist in housing, in income, in education, in access to health care, certainly implicit bias, chronic underinvestment in public health. These are all parts of the conversation. We're learning more in medicine about the effect of the toxic stress that causes weathering in people of color from the daily microaggressions that people endure. We're learning more. We don't have all the answers, but this is a piece of a solution that's really important. And so I want to thank you, Senator Mann, and thank you again, Ms. Mitchell, for your work and for being here.
Senator Mann, I would echo those comments. As someone who cares for patients in the hospital, I appreciate this bill, and it is definitely needed. I can't imagine, being in that position and not having to have a support person with me. And so appreciate you bringing this bill forward, Senator Mann, and appreciate the exceptions that may be needed in certain circumstances. And as Senator Morrison said so well, certainly there is more work to be done in this space of institutional racism within healthcare. And so look forward to this committee doing continued work on that. So, any other comments or questions, members? All right, Senator Mann, would you like to move your bill?
Yes, Madam Chair, I'd like to move SF 46. 406. As amended, be recommended to pass.
And this will go to the floor. All right. Members, all those in favor? Aye. All those opposed? No. The motion passes, and the bill will be sent to the floor. Thank you, Senator Mann. And next, we will go to the next Senator Mann bill, 329.
Thank you, Madam Chair.
Senator Mann, would you like to address your amendment first?
I would, please. I would like to move the amendment.
Senator Mann moves the A1, which members should be in your packets. I'll give members a moment to find that. So Senator Mann moves the A1. All in favor of adoption of the A1 author's amendment, please say aye. Aye. All those opposed? The amendment, the motion passes and the amendment is adopted. Senator Mann, to your bill as amended.
Thank you, Madam Chair. In the United States, breast cancer is the most commonly diagnosed cancer in women, and it is the second leading cause of cancer death in American women. Breast cancer mortality rates have decreased substantially during the past 50 years, and this decrease has been attributed to early detection and improvements in breast cancer treatment. What Senate File 329 does is remove costly barriers to early breast cancer detection so that we can continue to make strides in these rates, but most importantly, we can save lives. Mammograms are an essential health benefit that patients have access to at no cost. However, what sometimes occurs is that the mammogram is inconclusive and the patient will require one or more follow-up tests. These follow-up tests are not considered essential health benefits and oftentimes will cost the patient hundreds, if not upwards to $1,000. So understandably, people put off getting these tests, these follow-up tests, and put off getting their complete screening. We are doing this group of patients a very large disservice because catching breast cancer early saves our healthcare system money, and most importantly, again, it saves lives. So today I ask you to support this important work. And with that, Madam Chair, we do have a testifier today.
Thank you, Senator Mann. We have two testifiers. So next we will go to Ms. Koch. Please state your name for the record and proceed with your testimony.
Good morning, Madam Chair and committee members. Thank you for having me today. It's been a minute since I've been in front of a Senate committee testifying. My name is Amy Koch, and I'm here on behalf of Susan G. Komen and my family in support of 329. My Aunt Laura tells the story of visiting my great-grandmother, and one morning while they were getting dressed, she noticed that my great-grandmother had like deep, jagged scars across her chest. And she asked her, as a kid will do, "What's that?" And my great-grandmother replied, "That's so I can spend more time with you." What my great-grandmother did not know is that those scars would run much deeper than she could imagine. The same scars were on her daughter, my grandmother, who died in her 70s. Those scars ran across my mother, her granddaughter, when she died on June 17th, 2012, at the age of 64. And those scars are on her great-granddaughter, my sister. But the good news with my sister is that we caught it early. And it was a preventative double mastectomy that we hope will allow her to be with us for a very long time. An estimated 16% of women screened with modern digital mammography will require follow-up imaging. Senate File 329 ensures that those women have the required diagnostic screening covered. Family history, anomalies, dense breast tissue, or a previous bout with breast cancer are all reasons that a deeper diagnostic may be needed. Screening for this is tricky, and I'll go into a little detail. But women, particularly with dense breast tissue, are more prone to breast cancer. It's a little unclear why. And on a basic mammography, fatty tissue shows up dark. Dense breast tissue or breast tissue shows up white. Unfortunately, so do tumors. So you're more prone and it's tougher to find. And that's what differentiates this from other cancer screenings. The Department of Commerce has evaluated the language in this bill, and they state very clearly that they have determined it is not, repeat, not, considered a new state mandate benefit under the ACA, as the bill clarifies existing benefits under the health plans. 2 years ago, I had an abnormal initial screening, my second. My family history and dense tissue required further diagnostic screening. After the ultrasound, I received a bill for over $800. I called my insurance company thinking I had somehow wrongfully been billed because screening is covered. I was told I only get the initial. For me, this was a surprise, annoyance, and expensive. But for many women, they cannot afford the additional expense, and they will forego this important screening. I have seen the costs and the devastation associated with misdetection up close and very personal. The tens of thousands of dollars that were spent on my mom's double mastectomy and chemo and subsequent radiation. Thousands more were spent on her second round of chemo and radiation because the cancer had already moved to the lymph nodes. Then there were the thousands on the brain scans for the headaches and that appointment where the doctor said, "Your mom's brain is full of cancer." And finally, the money spent on the hospice nurses, the bed, the equipment, and the every other day delivery of drugs because mom couldn't speak anymore and I had to make sure she had enough to ensure she was not suffering. But early detection saves those costs. My sister Natasha is winning the fight because of that early detection. It saves pain, it saves suffering, and it definitely saves lives. I ask that the members support Senate File 329 and help more people spend the time with the ones they love.
Thank you, Ms. Koch, for your testimony. Our second testifier is Mr. Andreessen from the Minnesota Council of Health Plans. Please introduce yourself for the record and proceed with your testimony.
Thank you, Madam Chair. Members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans. We're the trade association for Minnesota's nonprofit insurance plans, which include Blue Cross Blue Shield of Minnesota, Health Partners, Medica, Sanford Health Plan, and UCare. So my testimony today is mainly just on how this will operationalize if passed. And I just want to kind of reinforce which markets this would apply to, with the way that insurance is regulated by the federal government. Not all markets can be regulated by the state. And so if passed, this would apply to the individual markets, so the MinShare exchange that people buy their insurance from, smaller employer group markets, Medicare, Minnesota Care, and the CGIP program. It would not apply to Medicare and the larger employer markets. Also, there's no language in the bill that addresses the cost of these services. And since those costs we assume will be staying the same, the costs associated with these that would normally be collected through to the provider for copays and coinsurance would be applied either through the premiums or through cost sharing in other ways. So in the group markets, such as the small group or CGIP, that money would probably be going through into premiums. In the individual market, it's a little bit different because the products that are on that market have to fall into one of four metal levels with tiers. And each of those are defined by a ratio of premiums to cost sharing. And so like a bronze metal plan is 60% premiums, 40% cost sharing. So if under this bill, if we remove that portion of cost sharing of that 40%, we're going to have to make that up somewhere else in order to comply with federal guidelines. One question we have is on the bill is what services would be covered under this. Right now in section 1 subdivision 5, it says requires additional diagnostic services or testing after a mammogram. So we're not clear if that means an additional mammogram, biopsy, pathology, kind of where does that end? So we just want some guidance on that so that there's no confusion or frustration on how this gets coded if enacted. And lastly, just wanted to address a statement that's been made in a letter in your packet, 'cause, you know, as we talk about affordability of healthcare. And there's multiple sides to this because, and namely, I would just want to point out the letter from Reyes Radiology. They're a radiology group here in Minnesota, which was recently acquired by Wellspring Capital Management, which is a private equity firm out in New York City. In their letter, they say, more than ever, we must work to eliminate barriers to care, and the patient's inability to pay should not prevent them from obtaining a potential life-saving and cost-saving early diagnosis. We completely agree with that statement. Cost should not be a barrier to access care. But if the authors of this letter feel the same way, the best way that they can actually solve that situation is lowering the cost of the services they provide. The costs associated with insurance is, you know, between premiums and copays and coinsurance is a direct reflection of the cost of care. And in this case, copays are what they are because of what Reyes Radiology and other groups charge for their services. And imaging costs thousands of dollars. So it's unfortunate the letter doesn't address their role in healthcare unaffordability, rather than just looking at insurance companies and how we structure our plans to help patients afford their care for the medical bills that they themselves are charging. So hopefully we get to see some changes from their end as this bill moves forward. That was my testimony. Thank you.
Thank you, Mr. Andreessen. Members, questions and discussion? Senator Utke.
Thank you, Madam Chair. And just to dig down a little bit more on that, where after must provide coverage for additional diagnostic services. Some of those are covered, if not the majority. What are we missing?
Senator Mann.
What do you mean some of those are covered?
Senator Utke.
I mean, if there's care needed beyond the mammogram, care is covered. Like Mr. Andreessen was leading to me it's wide open with that. What are we missing that we're trying to cure with this? I see that portion, and then of course I can see the line right below it deals with paying for it, who's cost sharing. But first of all, let's dig into the care.
Senator Mann.
Madam Chair, so I think first off, the following steps are not covered, and that's the purpose of this bill, is because people are paying like $1,000 out of pocket in the event that they need a follow-up MRI, for example. So after a mammogram, if the mammogram is inconclusive, it depends on the reason why, but follow-up tests will include a follow-up mammogram, an ultrasound, an MRI, or a breast biopsy even, to ascertain is that thing that we saw bad or not, right? Which is the purpose of a screening test. Is there something there? And so generally, for many people, none of those things are covered as a follow-up and part of the screening process.
Senator Utke.
Thank you, Madam Chair. I'll let, if there's a couple other questions, I just want to look at the fiscal note here too, because I've got some questions there.
Sure. Senator Morrison.
Went the wrong way. Thank you, Madam Chair. Thank you, Senator Mann, and thank you, Senator Koch. I kind of wanted to go big picture with this bill, and because it speaks in so many ways to all of the different ways that the system that we have created is failing us. Having an abnormal mammogram result is a very stressful situation, and there is a non-trivial number of false positives, particularly with women who have dense breast tissue. So we need to, I appreciate your comments too, Mr. Andreessen. It's complicated. It's not all the fault of the nonprofit health plans. But we need to have a larger conversation about how we're going to address our American healthcare problem. We're spending more money than anywhere else, and we're getting worse outcomes. We're creating situations that put Americans into severe debt that they can't dig their way out of. I appreciate this bill very much. I've taken care of so many patients who this has been a struggle for. So making sure that they can get the follow-up testing, diagnostic care that they need is key. So thank you for bringing this forward, Senator Mann.
Other comments or questions, members? Senator Edke?
Thank you, Madam Chair. And part of this goes back to, I guess when I saw this bill, I went, there's a golden oldie, because I saw it at my desk all last year and beyond. It's just that we just can't keep adding these mandates to our insurance program, to our health plans, and expect this system to continue. You know, I just happen to have one in front of me that was one of the letters that came to us from the chamber, and it explains it pretty well too, is for every time we add a mandate, and this legislature over the years has been known as adding a lot of mandates to the health plans. And then at the same time, we hear people complain about the cost of insurance. They can't afford it. They're going without. Now they walk into the emergency room and don't pay. It's a balancing act all the time. And at some point, where does personal responsibility come into this equation too? I've had good insurance, but I've still paid a lot out of pocket because we're all different and we're going to run into different things. We're very sympathetic to this whole thing with the mammograms. I mean, that's serious, but there's a lot of other serious things out there too. And my question last year always was, what's next? We had mammograms this time. We've got heart disease. We've got all these things that are very, very important. And it usually starts with people that have been close to these things, and I fully understand that. But that's my concern with this. I just think we keep adding more things to the plate, and at some point, who's going to be able to afford this? And, you know, so, you know, it's a balancing act, and I guess I just like you to take that into consideration because to me, as I looked at it all last year, it was like, this is not something we should be doing. But.
Senator Mann.
Madam Chair, so first of all, it is not a mandate, right? It is simply a clarification of existing benefits. Second of all, you're absolutely right, Senator Uckey. Our healthcare system is falling apart, right? Because it is run by entities who need to profit off of sick Minnesotans. That's what American healthcare is, right? And so for us to say we can't keep making them cover health benefits, well, what is the purpose of health insurance? And this idea of personal responsibility, if I fall and break my femur and I cannot afford surgery and hospitalization and a long-term care stay, what am I supposed to do, right? It's not about personal responsibility. It's about healthcare, which is something that we will all use in our lifetime, all of us. And so what we do in America and in Minnesota is we spend on the outcomes. We spend after the fact. We spend after the cancer is there, after the cancer is progressed. So we're spending thousands upon thousands of dollars on something we could have spent a little bit more months ago and prevented, right? We could have prevented poor outcomes. We could have prevented death. We could have prevented the suffering of all the family members of that patient. And so we have to rethink the way we offer healthcare in this country and in this state. We need to rethink the meaning of healthcare in this state. And we need to, again, and I'm the 800th person who has said this, we need to invest in prevention. And that's what we're doing with this bill.
Madam Chair, and Senator, if I can say, this is about personal responsibility and being thoughtful about healthcare and working ahead of the problem. I outlaid the costs associated that were shared across insurance companies with my mom's death. And I do that very seriously. And I take my responsibility in this very seriously. My family, my entire family does. We intend to stop this in its tracks. It's not about hurt and pain entirely. It is also about saving dollars on the outside and being smart about prevention. And, thank you for saying, this is simply a clarification. It's not an additional mandate. I know we have a lot of that discussion here. This has been clearly stated. It is a tricky thing to screen for breast cancer, particularly for women who are more prone and have dense breast tissue. And so that was something we didn't know when this initial mandate was put into place, but we know now we can be smarter about screening. And so that's really why we brought this bill, and thank you for your time.
Senator Radke.
Thank you, Madam Chair. And I agree with a lot of what you said, except the fact that it is a mandate because it's not being covered at this point. And so I guess that's where, however we want to label that, it's something that if it's not being covered, we are mandating coverage. Is that correct, Mr. Andreessen?
Mr. Andreessen.
Madam Chair, Senator Udke, I think this is more about where the costs are being paid, whether it's going to be being paid through premium dollars, which the enrollees pay to health plans, which then plans use to pay medical bills, or if it's being collected through co-pays and co-insurance. What's being covered or being outlined in this bill, this is all covered benefit. Some of it is preventative, like an initial mammogram. That is something that's preventative. It's covered. You don't pay out of pocket for that. If there's additional pieces, it gets coded as diagnostic. It's still covered. There's some premium dollars that are going towards that bill, but there's also co-pays and co-insurance that are likely assigned to it. So that's what this bill is about, is whether all of it will be paid in premium or if it'll be under cost sharing.
Senator Radke.
Thank you, and thank you for that, because that was the question I asked very early on, was about these coverages. Those items are currently covered. We're just, as I saw it in the beginning, basically arguing over the copay. Do we make a copay on this second and third visit? And now we're down to things that are totally different. Because I was very concerned about the coverages, which now is covered, but the copays, that's just part of insurance. I mean, if Senator Mann, if somebody comes to see you this week and we got to follow up next week, it's another office visit. That's kind of what we're looking at here. We as a consumer are going to have those copays and office visits until we meet our deductibles. So I guess that's why I was against it before and still don't like this. I don't think we need to separate out and, for this particular treatment. Again, we're all sympathetic to the cause, but there's many more just like it. And, I think we need to treat them all equally. Thank you.
I would just interject that coverage does not equal care, and just because you have coverage, if you cannot afford to pay the out-of-pocket cost or the copay for that care, it may mean that you do not get care. Senator Mann.
Thank you, Madam Chair. I was just going to say the same thing. We have some of the highest out-of-pocket rates in the entire country in Minnesota. People have insurance, but they can't access that care. And so, when people buy a product, they expect that they will have access to the care they need, and then come to find out when they have an abnormal mammogram, they do not have access to that care. So,
Senator Morrison.
I think Senator Liskey was first.
Senator Liskey.
Thank you, Madam Chair. Senator Mann, maybe somebody else out there can answer this question. We're talking about mammograms. I know we like to, on this committee, for some reason, talk about colonoscopies as well. I would like to ask, I guess, any of the doctors in the area, or maybe a coverage question. If we have an abnormal colonoscopy, do we then pay or cover the next step after that, where this would be a similar question, I guess? Mammograms would follow that same line of thinking, I guess. That's what I'm asking.
Senator Mann.
Madam Chair, so a colonoscopy is a little bit different than a mammogram, right? Because you can have a screening mammogram and it's inconclusive. A colonoscopy is a direct visualization of the colon, and so you're in there, and if you see something, you can biopsy it right away, so it's all part of the same thing.
Senator Liskey.
Sure. So, but of course, we still have abnormal findings in colonoscopies that may lead to a need for follow-up post-colonoscopy. So you may, yes, you get the tissue for a biopsy, but maybe you need to have follow-up on post-biopsy, post-colonoscopy. Are those services currently covered, at which point it would be a same concept here, right? We have a mammogram that has an inconclusive result or a result that might be a false positive, but we're not sure. And that's, I guess, what I'm trying to get at is these types of services for other cases would be covered. Why isn't the mammogram covered or the second necessary mammogram covered? We're trying to figure that out. And that's what I guess I'm trying to ask.
Senator Mann.
Madam Chair, so why the follow-up imaging for a mammogram is not covered is a good question, and that's what we're trying to fix today. And it's still not the same as the colonoscopy, right? Because you get in there, you see it, you biopsy it. Once the biopsy comes back, you have a diagnosis. That's not the case with the mammogram.
Senator Morrison.
Thank you, Madam Chair, and thank you for that question too, Senator Liskey. Correct me if I'm wrong, Mr. Andreessen, but in the case of a colonoscopy, most commonly if you have a biopsy during a colonoscopy that's not cancerous, but it's something that needs to be followed, often there will be a recommendation to repeat a colonoscopy in 3 years, which would be covered.
Mr. Andreessen.
Madam Chair, Senator Morrison, yes, I think we're kind of going together with coverage versus how the bill gets paid at the end. So it's all covered, but it's whether the bill is applied strictly to premium dollars or there's cost sharing associated with it. So in that case, yes, it's covered. There might be premium dollars paying it. There might be copay associated with it, depending on how your health plan is structured. But this is all covered. It's just a matter of how the bills get paid.
Senator Morrison.
Thank you, Madam Chair, and thank you, Mr. Andreessen. I think Senator Liskey kind of made Dr. Mann's point that the follow-up should be covered. I just wanted to comment on this idea of bringing personal responsibility into breast cancer, and I want to thank you for sharing your family's story. I know it's hard to talk about, personal tragedies, and I'm so sorry that your family had to go through that, but thank you for being here and sharing it. I don't know where personal responsibility comes into being diagnosed with breast cancer, and I guess I would say that in some ways we are, and I appreciate your point, Ms. Koch, about personal responsibility, and there are ways in which I think we're preventing personal responsibility by not covering the follow-up, because you get a result that requires follow-up, and if you cannot pay for what is required of you in follow-up, you're unable to kind of follow the doctor's orders. So I would say this is a bill about personal responsibility and encouraging it.
Other discussion or questions, members? All right, so with that, Senator Mann, do you have a motion for your bill?
I do, Madam Chair. I move that Senate File 329 as amended be recommended to pass and be re-referred to the Committee on Commerce and Consumer Protection.
Very good. Senator Mann has made her motion. Members, all those in favor, please say aye. Aye. All those opposed? The motion passes, and the bill will be sent to Commerce. All right, members, that is the last bill for today. There being no further business before this committee, we are adjourned.